Hello students, today's session is on aplastic anemia. So in the previous classes we had been discussing about the different types of anemia. Among the different types, one type is aplastic anemia. Aplastic anemia represents, so the objectives of the class is to know what is aplastic anemia, to explain the types of aplastic anemia and their management. Aplastic anemia is characterized by pancytopenia in blood film due to hypoplastic bone marrow. Or in short, there is decreased production of the three lineages of cells resulting in pancytopenia. That's RBCs, WBCs and platelet are decreased, resulting in a pancytopenia picture in blood film due to the hypoplasia of bone marrow. There are two types of aplastic anemia: primary idiopathic acquired aplastic anemia and secondary aplastic anemia. So aplastic anemia can be classified into primary idiopathic acquired aplastic anemia and secondary aplastic anemia. Primary idiopathic aplastic anemia, the basic problem is a failure of the pluripotent stem cells because of an autoimmune attack producing hypoplasia of the bone marrow with a pancytopenia in the blood. So basically it is the autoimmune destruction of the stem cells resulting in hypoplasia, which results in a decreased production of cells resulting in pancytopenia in blood film. Now how does this primary aplastic anemia present or aplastic anemia present? Both primary and secondary present with almost the same symptoms and signs. So symptoms of bone marrow failure like anemia, bleeding, infections. Because the patient is having pancytopenia, the features of anemia will be present. Because there is leukopenia, the patients are prone for infections, and when there is a decreased platelet, it can result in bleeding. The full blood count would demonstrate pancytopenia with a low reticulocytes. So a pancytopenia with a low reticulocyte indicates a aplastic anemia or a hypoplasia of the bone marrow or a hypofunctioning bone marrow with macrocytosis. And when you do a bone marrow aspiration or a refined biopsy, there will be hypocellularity and possibly a dry tap because of the less cellularity of the bone marrow. The severity of aplastic anemia is graded by the Kamita criteria. Now the Kamita criteria divides aplastic anemia into non-severe aplastic anemia, very severe aplastic anemia and severe aplastic anemia. Severe aplastic anemia, the criteria that they use are, they look for marrow cellularity, and if the marrow cellularity is less than 25% plus at least two of the following: the neutrophils being less than 0.5 into 10 raised to 9 per liter, platelets less than 20 into 10 raised to 9 per liter, and retic count less than 20 into 10 raised to 9 per liter. So if at least two of these plus a marrow cellularity less than 25%, then you call it as severe aplastic anemia. Very severe aplastic anemia is when the features of severe aplastic anemia is met with the neutrophil being still low, that is less than 200. So when the neutrophils are less than 500, platelets less than 20,000 and retic count less than 20 into 10 raised to 9 per liter, with the marrow cellularity less than 25%, for 25 to 50% with less than 30% residual hematopoietic cells. So if it is between 25 and 50 with less than 30% hematopoietic cells plus two of the three criteria mentioned, it is called severe aplastic anemia. It is called very severe aplastic anemia when the features of severe aplastic anemia are present but neutrophils are less than 200. And non-severe aplastic anemia is when the aplastic anemia not fulfilling the above two criteria. So it can be classified as severe aplastic anemia, very severe aplastic anemia and non-severe aplastic anemia. Basically it is based on the amount of cells which are present or the quantity of cells which are present or the cellularity of RBC, WBC and platelets. But for RBCs, retic count is used, platelet and neutrophil count is used for WBC lineage. It is called the Kamita criteria. Now, management of primary idiopathic acquired aplastic anemia, the patients will have to be supported with blood transfusion. If there is anemia, correct anemia, so blood product transfusion. Like if there is anemia, you give PRBC. For platelets with bleeding, you give platelet transfusion. And if there is infection, you give aggressive treatment of infection with antibiotics. In people with less than 35 years, the treatment of choice is an allogenic stem cell transplantation, homologous stem cell transplantation. And in older patients in whom when the stem cell transplantation is not possible, immunosuppressive therapy is used with anti-thymocyte globulin and cyclosporin. So treatment of choice in older patients or who are not fit for a stem cell transplantation is immunosuppression with anti-thymocyte globulin and cyclosporin. In less than 35 years, it is the treatment of choice is stem cell transplantation. The thrombopoietin receptor agonist L-Thrombopag has produced trilineage responses in patients who fail to immunosuppressive therapy. So in patients in whom immunosuppressive therapy fails, a trial of L-Thrombopag can be done. In non-transplanted patients may relapse, or other clonal disorders of hematopoiesis may evolve, such as paroxysmal nocturnal hemoglobinuria, myelodysplastic syndrome, and AML. So patients with aplastic anemia can develop other clonal disorders in future, and or they can have relapse of aplastic anemia, or they can develop other clonal disorders like PNH, myelodysplastic syndrome, and AML. So patients with aplastic anemia must be followed up for long term. So the basic treatment is always support with blood products, and in younger patients you go for stem cell transplantation. In older patients you go for a immunosuppressive therapy. Secondary aplastic anemia occurs when there aplasia or hypoplasia of the bone marrow suppression occurs because of other causes, and the most common and notorious being drugs. There are many group of drugs which can result in aplastic anemia. Among them, the most notorious are the cytotoxic drugs, the anti-cancer drugs, or the anti-neoplastic drugs, which will cause bone marrow suppression and can result in aplasia and aplastic anemia. Antibiotics like chloramphenicol, sulfonamides can result in hypoplasia. Anti-rheumatic drugs like penicillamine, anti-thyroid drugs like carbimazole, propylthiouracil. So it's important to counsel the patients in whom you start anti-thyroid drugs like carbimazole to be wary of agranulocytosis. So if they develop fever with throat pain, they are always advised to look up for the complete blood count, because carbimazole can cause agranulocytosis, which can present as infections. And immunosuppressive drugs like azathioprine, anticonvulsants. So drugs can result in secondary aplastic anemia. Chemicals like benzene, toluene, solvent misuse, glue sniffing, insecticides like organophosphorus, radiation. So patients who undergo radiation for malignancy can also have the radiation can also result in bone marrow dysfunction, hypoplasia of the bone marrow, and lead to aplastic anemia. Viral hepatitis, pregnancy, and paroxysmal nocturnal hemoglobinuria, PNH, is one condition which can again result in a secondary aplastic anemia. So the most common and the notorious ones are the drug-induced aplastic anemia. So it's always important for patients who present with pancytopenia to look for drugs which can result in drug history for drugs which can result in pancytopenia, and also to ask for homeo and ayurvedic treatment, because any type of treatment, any traditional treatment, etc., because any drug can result in bone marrow suppression. So you have to actively look for secondary causes of aplastic anemia. The clinical features are again due to cytopenias, but in some instances the cytopenias are more selective and may affect only one cell line, mostly neutrophils. So neutropenia. In chemotherapy associated, usually it is neutropenia that happens, which can predispose the patient to infections. Frequently, this is an incidental finding with no in health. Otherwise, you might be evaluating for fatigue, and then you come across you on investigation you find that the patient is having pancytopenia. The clinical features and methods of diagnosis are same as for primary idiopathic aplastic anemia, but an underlying cause should be treated or removed. But otherwise, management is as for the idiopathic form. So you support the patient with blood transfusion if there is severe anemia. You give platelet transfusion if there is bleeding. You treat infections, and if you can identify a trigger or a factor which can result in pancytopenia, you remove that drug. Like patients who are taking methotrexate for rheumatoid arthritis or other rheumatologic conditions, they can develop neutropenia and pancytopenia or bone marrow suppression, and you immediately stop the drug and you give folic acid rescue, because it is an folate antagonist, folic acid rescue to improve the count. So aplastic anemia can be classified as primary and secondary. In secondary, there are other causes like drugs which can result in pancytopenia. So aplastic anemia presents with pancytopenia in the blood film, and bone marrow might show a dry tap or hypocellularity. Depending on the cellularity of the bone marrow and the cell lineages, you classify the severity of aplastic anemia. Treatment of aplastic anemia is basically support with blood transfusion and other blood product transfusions. In young patients, you go for a stem cell transplantation. In older patients, you give immunosuppressive therapy with anti-thymocyte globulin or cyclosporin. And in secondary aplastic anemia, you remove the cause, identify the cause which is causing aplastic anemia, or the treatment remains the same. Thank you.